Aloha, my name is Josh Green. I'm your host on Healthcare in Hawaii. We've been having a very vibrant discussion over the last 10 weeks about healthcare in our state. We've spoken about healthcare transformation, the role of the insurance companies, what our hospitals do in our state, and what we're doing with the Health Information Exchange and all of these larger programs that go on around the Affordable Care Act. I thought we'd change directions a little bit and really bring it back down to earth. As you know, I'm an emergency room physician, and I spend so much time with other physician colleagues working on the actual problems of health and healthcare access in our state. So I thought I'd bring a different kind of expert, a clinical expert, to our roundtable discussion today at Healthcare in Hawaii. Today I'm very pleased to have Dr. Geoff Galbraith, a physician who runs Hospice Hawaii here on Oahu. Geoff is the medical director of this program, and I thought this was a very important topic to introduce to our viewers. Hospice care in our state and across America provides a very fundamental service to people at end of life. And before getting into too much detail, I want to turn this discussion over to Dr. Galbraith to really give a basic introduction in our first 15 minutes and then dig deep into this piece of our healthcare system over the next hour. Dr. Galbraith, great to have you.
Thank you, Josh. It's great to be here.
I'm so pleased to have a fellow colleague, a physician here to discuss what I think is one of the most important parts of our healthcare system, which is healthcare when you need it, often at the end of life. So why don't you tell us a little bit about yourself so our viewers can get to know you, and then we'll dive into the subject.
My original interest was in internal medicine, and I had a remarkable and very fulfilling career with the Permanente Medical Group here in Hawaii with Kaiser Permanente. Mm-hmm. At the point I retired, I had been a volunteer in hospice care for several hospices here and with the palliative medicine team at Kaiser Permanente, and through a series of unforeseen fortunes, I was able to completely transform my career and enter hospice and palliative medicine.
So why don't you unpack, before we get into too much depth, tell us what palliative medicine is for our viewers.
I think the easiest way to understand palliative medicine, it is a medicine that is first of all provided by a team. You have your physician, you have your nurse case manager, often your advanced practice nurses, right, your social workers who are trained in the psychology and the psychosocial support in addition to resource support. You have your spiritual support with your chaplains. You have your home health aides, so people that are expert on taking care of your loved one's body, bathing, repositioning, doing those kinds of things that we're sometimes afraid of in a home environment. And that's where hospice mostly takes place.
Okay.
And we have the adjunct support of massage therapists, art therapists, music therapists, pet therapists. Now, all of that put together, we can call palliative care.
Okay.
Now, in the hospital, palliative medicine is focused around reducing the symptoms of suffering. We think about pain, we think about shortness of breath, we think about our bowels being painful or obstructed, we think about those kinds of suffering. So our experts in the community, and I want to take my hat off to two palliative medicine experts, Dr. MJ Shimoji. Mm-hmm. She was the first teacher for all of us at the University of Hawaii's John Burns School of Medicine and Geriatrics to talk about palliative medicine.
Right.
And Dr. Daniel Fishberg, who has been the palliative medicine specialist at the Queens Medical Center over the past decade. MSA is now the palliative medicine specialist at the Castle Medical Center. So we owe it to them that a whole group of physicians across the islands are now board certified in hospice and palliative medicine.
It's so interesting to hear you speak about this, because one of our areas of focus for the last several weeks has been a concept called the patient-centered medical home. And when I hear you describe what palliative care and the palliative care team looks like and the way it's translated into hospice care, it really makes me think very quickly and reminisce about those conversations that we've just had about how healthcare is becoming a much more team-based approach to the care of patients. And it's not simply about a quick diagnosis from a physician and then a direct course of treatment. It actually is about a larger body of individuals, the doctor and the nurse practitioner and the case managers and the massage therapists, all providing care. Are some of the roots of patient-centered medical home, do they have something in common with palliative care and its training?
Very much so. The notion of the patient-centered medical home is organized around the focus on the patient. Where does she or he want to be? when they're informed about care, when they received care, when they're engaged. And for people with chronic illness, the place they want to be is at home. So we focus on the home visit, and I'm fortunate enough to spend most of my time in people's homes throughout the community, listening to their stories, understanding their values, what do they want in this part of their life where they have a chronic illness, and they've been told this may be life-ending. At the same time, they have their own values, they have their family support structure, they know what they want, and in part, my job is to reassure them, you can be confident because we're going to eliminate pain that would interfere with you doing those things. We'll take care of that depression with you that you might have because you have a chronic illness. So our psychosocial support, our therapy, our sense of engagement, and building your trust and building your family's trust is about being well in this part of life. And for me, the patient-centered medical home is all about how do you empower the individual to be well at wherever they want to receive or the point of care that's appropriate.
Well, I'm so pleased to have this conversation with you, and this has happened on a few occasions where I actually, I begin to see the picture even more broadly when I'm just able to talk to a guest on our program, because it hadn't occurred to me so clearly how integral the palliative care discipline and the hospice discipline has to be a part of our, not just our whole healthcare system, but about this movement if it's going to actually be important going forward, if it's going to continue to define in some ways what a lot of people are talking about as the healthcare system of tomorrow. So I thank you for that. Already, I think it's been a very important discussion. Now, let's take a step back here. You said that you, after internal medicine, came to the training of palliative care. Is this a relatively new discipline for us in America? How far back does this area of medicine go?
This area of medicine is now maturing, so that we've just completed the stage where an individual physician could use his or her experience to validate sitting for a board certification examination with all of the American Board of Medical Specialties.
Okay.
So we now have palliative medicine physicians that can certify in emergency care, in pediatrics, in surgery, even radiation oncology. So the idea is that now this is mature, and I'd say over the past 10 years, the whole art and science of palliative medicine is both coming to fruition where you now have to take a fellowship to be able to sit for your boards and be board certified. At the same time, the research is now coming to fruition where after 10 years our evidence base for what removes suffering most effectively, what are the medications that if used discriminately can really provide benefit and relief without complications. So those studies across the world are coming to fruition, so this is a perfect time.
It really is so interesting because though I'm relatively new to medicine, I graduated in 2000, it really wasn't yet a discipline. This is the first time I've ever seen an absolutely new discipline of medicine emerge since I began my career, and it's very gratifying to see some change, because in many areas of healthcare I've noticed there hasn't been that much change. Not as much change as I might have expected. In some of the subspecialties, they do wonderful job for patients, but to see a whole new branch of medicine emerge, that there's a way to go get training and to have evidence-based care to affect the outcomes of people's lives for the better in a new way, it's really exciting. Are you one of the only palliative care physicians? How many do we have in Hawaii?
We're very fortunate, as I said, in Hawaii. We have hospices across the island network. We have 4 wonderful hospices on Oahu, a hospice on Molokai, which is part of Hospice Hawaii, our organization. Soon coming to Lanai as part of the Hospice Hawaii group. On Maui, we have Hospice Maui. On Kauai, Hospice Kauai. On the Big Island, 3 hospices covering Kona, Waimea, Hilo. Wonderful. And most of the hospice care that's delivered in our state are by subspecialists in hospice and palliative medicine, the vast majority.
So I want to get to the whole geographic spread and how many people are in hospice care and what the right time to go into hospice care is in our second segment. But for now, let me understand a little bit better. You, in your case, you did internal medicine and then did additional training and expertise in palliative care and got certified. Tell me more about some of these other doctors. They're neurologists, they're oncologists. Did they take a year off from their career to go and get extra training? Did they do it separately? How is it done?
Well, it's typically done side by side, but now it's a changing landscape, so that now you do have to take a year out of your career. So no matter where you are, you have to set aside a full year of intensive training in a palliative medicine fellowship.
Okay.
And when you've completed that 12 months, you're then qualified to sit for the board and practice palliative and hospice medicine. You may return to surgery,
right.
You may return to pediatrics, you may return to your discipline and have this advanced certification so that you're providing, in addition to your expertise in anesthesia, you provide pain management in the hospital, you provide symptom management in a variety of ways, and more, hospitals are recognizing if we don't give you a team, you can't be optimally effective.
Right. So you're saying after a physician has gone and gotten that additional training, they'd be wise to join a hospital that is going to commit themselves to having that care coordinator, the nurse practitioner, the nurse, the social worker, maybe someone with a spiritual component in their life,
Yes.
all to helping out, because otherwise it won't be as effective. Is that what the evidence shows?
It's essential. The evidence helps us understand that the individual physician is often no more effective than your oncologist would be with pain control or other types of suffering reduction.
Yes.
Because of their specialty training. But the notion of treating the patient, we can't forget that the family is there. Often the family is misunderstanding what is happening with my loved one. No one's having the communication with me. No one is here that is bringing us together spiritually so that our faith can buoy us in this tense time in our life when we're in the hospital or we're going home and we're afraid of what's going to be coming next. So it requires the team and all of the good evidence that says, number one, early palliative care improves symptoms, improves satisfaction, reduces hospital admissions, reduces critical interventions at the end of life, and gives people a sense of really being cared for. Without the team, that can't really happen.
Yeah, I hear what you're saying. Now, it's so valuable a part of our discussion because that has come up multiple times about how long people stay in the hospital from a different perspective. People sometimes are talking about health economics, or they're talking about the impact of the Affordable Care Act, or all these different questions. That's why I wanted to have you here to talk about the actual health benefits of the system and why we do this. Now tell me this, when you're at a hospital, do all of our hospitals give access to palliative care and hospice care, or is it just a few of them?
Right now, I think it is a few, but the few is beginning to create that critical mass where every hospital recognizes the need for palliative care. We have also the gift of HMSA as an insurer,
Yes.
and Kaiser Permanente as an insurer, where they are advocating additional incentives to build a palliative care team, to have those conversations in the hospital, to refer early, so that we're not only doing this as caregivers, but our insurers are supporting us and saying this is the right thing for all the people in Hawaii.
It's fascinating to hear that this partnership has come together, and I so appreciate that you mentioned that, because I'll be honest, I have had a very good rapport with HMSA and Kaiser in the recent years and months, not just on this program, but also when looking at what people in Hawaii actually need. I found them to be very accommodating these days to look at emerging trends in healthcare, like palliative care and hospice care, to make that an integral part of what we have access to. We're going to take a break here after our first 15 minutes, and I think then when we return, we'll come back and talk about what the type of patients are that qualify for hospice care and what their needs are. So let's take a break. I'm Josh Green at Healthcare in Hawaii, here with my guest who's speaking very passionately about hospice care and palliative care. That's Dr. Geoff Galbraith. Thanks for joining us.
Aloha, I'm Jay Fidel with ThinkTech. ThinkTech is a 501c3 Hawaii nonprofit corporation. We began ThinkTech in the year 2000. At ThinkTech, we work to raise public awareness about tech, energy diversification, and globalism in Hawaii. We do 20 live stream talk shows every business day, and we do a weekly TV show on OC16. We pay the bills with donations from our supporters. Won't you help us by making a donation? All you need to do is go to our website, thinktechhawaii.com, and click there on the Donate button. We hope that you like what we do and that you will support us and help us continue to do it. Thanks so much for watching and for helping. I'm Jay Fidel of ThinkTech. Mahalo.
Aloha. I'm Nicole Horry for ThinkTech. For nearly half a century, the Hawaii Foreign Trade Zone No. 9 has brought the benefits of the Foreign Trade Zone program to Hawaii businesses and entrepreneurs. DBET, the Department of Business, Economic Development, and Tourism, operates Hawaii's Foreign Trade Zone program to encourage international business and economic development. The Foreign Trade Zone's mission is to increase the amount of international trading activity in Hawaii, thereby providing employment opportunities for the residents of our island state. For more information, see ftz9.org. I'm Nicole Horry. Mahalo.
Aloha, this is Josh Green with Healthcare in Hawaii, State Senator and Emergency Room Doctor on the Big Island. Today I'm joined for a passionate discussion about hospice care and palliative care with Dr. Geoff Galbraith. In our first 15 minutes, Geoff and I have had a really important discussion about this new piece of healthcare that's emerged in the past 10 to 15 years across the country that works to provide a respite from pain and suffering. It's not completely the same traditional healthcare you always had at the hospital, and that's what we're going to get into in the coming minutes. This is an area that is meant to focus on the entire patient. Dr. Galbraith was able to describe the team that comes together when someone needs hospice and palliative care, a team of a physician and a nurse practitioner, case managers, social workers, massage therapists, so many people that have experience in spiritual matters, everything meant to decrease a patient's suffering, their anxieties, and their greater concerns about what might happen at the end of life. I now want to come back to our discussion with Geoff and talk about really the nuts and bolts of what it means to go into palliative care and hospice care for the patient. So Geoff, why don't you, at this point in our conversation, tell me a little bit about a common circumstance in which a patient comes to you at hospice for care. How do they get referred to you? What's this patient often look like? What kind of diseases do they have? What's the circumstance?
If I may, Josh, I want to back up just a little bit and help our viewers and listeners understand that hospice is not a destination.
Got it.
Hospice is a service. It is a benefit that the federal government and our wonderful state insurance organizations provide for all of our citizens.
Okay.
And that benefit is implied or is brought into bear when someone has a chronic illness, whether it's cancer,
Yes.
or heart disease, or lung disease, or a neuromuscular disease, one of the defining diseases like Parkinson's disease, or some of those that interfere with someone's ability to live and is projected to be terminal. So the hospice eligibility begins with a prognosis where two physicians, you in the emergency room have known some patients,
Sure.
and me as a medical director can say together that is in our judgment
Yes.
that if this disease process goes untreated and its natural course takes place, this person is likely to die within 6 months.
Got it. So tell me a little bit more about that. You say that this is a service that's available for everyone. That means any patient, any age, if their circumstance with their disease suggests that they'll die potentially within 6 months, would be able to get it, whether they have HMSA or they're on a Medicaid plan or they're in Kaiser. So it's everyone.
It's everyone. My youngest patient came home at 6 days. My oldest patient just turned 105.
Wow.
So it is all ages, and it is all cultures, and it is all forms of our society. So the benefit is available to all. And when the benefit can't be paid for, all of the hospices in Hawaii across the islands provide charity care and are very generous. It's about the patient and family first. But for the most part, all of our people are insured for the benefit. Now, someone with cancer, and they have the progression of cancer, often their oncologist will say, we're at a place where we have done a couple of runs of chemotherapy. Your tumor has responded. It's not responding as much now, We're noticing that you're losing weight, you're not as active as you were. This may be a good time to talk about the benefit of hospice care, because this is an additional benefit, and I really want to emphasize this is an additional benefit that someone can consider for themselves or a loved one that takes the care team into their home. The majority of people in America have said, I want to die in my home.
Just last weekend, I had a patient, such a sweet lady, a 92-year-old woman. I saw her in the emergency room. Her granddaughter was one of the nurses at the hospital. Her single most important comment to me right out of the gate was, Dr. Green, whatever happens, I want to be able to pass away at home. I want to be able to die in my home, in my bed, near my family. That was almost all she wanted to convey to me. She had very serious end-stage renal disease. Her kidneys weren't working, for our viewers. She'd been sick for quite a long time, but that's what was important to her. And so we were able to activate palliative care and hospice care for her right away. And she was so relieved that instead of being in the hospital for 5 days and getting sicker there, or maybe getting a little better but languishing, that she was able to go home. And that sweet lady did die after 2 weeks. She died at home. Her granddaughter, because it was her granddaughter, didn't want to provide nursing. She wanted to be there as a family member, but she provided an incredible amount of support. And then the hospice team was there at her home when she passed. So it's exactly what you're describing. Now tell me a little bit more about some of the other patients that come into hospice care, so I think that we can put a personal face on it. You said there was a 6-day-old. What was the circumstance for, not that child perhaps, but a child that does end up in hospice care?
That child and others had congenital heart disease that was not operable. And we have fabulous surgeries for these youngsters with heart defects, but in this case, there were too many other genetic abnormalities. He went home. The intensive care unit provided a place for his parents to stay for 2 nights so that they could understand his care, so they got training there. Our hospice team went in, nurse, social worker, to interact with mom, with the husband, with the staff, with the baby, to understand, well, what's the kind of care that he's getting now, and then what changes would be necessary in terms of equipment or other types of support if he goes home. And so we put that together. He went home, and little James, and I'll use his first name, didn't live for the days that we thought, because we thought the prognosis was hours to days. He lived for weeks to a month. Both of their parents came to Hawaii. They were together as a family unit for an entire month. So important that people understand early palliative care referrals, early hospice support not only provides improved care, but also longer care, because all the big studies help us understand that hospice early, the same person without hospice suffers more and does not live as long as the patient that gets the hospice care.
That's fascinating. It's almost counterintuitive, because people, I think, out there who have some familiarity with just the words, or they read something in the newspaper about hospice care, they might have this misconception that it's some kind of death sentence. Really, what you're saying, it's an affirmation of the way to spend the rest of your life, and hopefully longer and in a more loving fashion with relatives and around. Because I know that a lot of people are just plain petrified about, what do I do if a relative or a loved one, a friend, is going to come home and I can't provide the care? Not many people have advanced medical training. They don't know what will it be like. So this is the opportunity to get that care at home, is what you're describing.
It is, and honestly, Josh, one of the most important interventions is to have a skilled home health aide go into the home, because people are afraid of things like bathing. They're afraid of, how do I organize dressing my loved one? How do I support standing and walking? What is the equipment that might be helpful for me? So every member of the team really makes a contribution. And then, I don't know if people know this, but in the hospices across the state, we talk about every single patient and their family every 2 weeks with all the disciplines present, so that we get the picture What are their goals? What are their values? And are we not meeting their needs in some way? Do we need to change our plan of care? And that continuously updating the plan of care is important. One other thing I want to just add is that includes their doctor. Their doctor gets an update on the plan of care from the hospice point of view, and he or she is always part of their care. We promote, continue to go to see your doctor. Continue to go to see your doctors. They get to continue to take care of you. Medicare has made an exception so that they can bill the way they normally would if they put a code on the front of the bill that just identifies this patient is in hospice, but they have the same relationship. And people think, if I go on hospice, I have to give up my relationship with my doctor.
Right.
I have to give up my relationship with the healthcare environment that I know, that I've come to trust. Not true.
I'm very glad that you were able to dispel that confusion, because I think a lot of people might have been under the impression that you're turned over to an entirely different healthcare system, when actually this is an integrated system where the patients, providers, nurses, nurse practitioners, their doctor are able to have ongoing involvement. And I think that's also very important, because a lot of people have a primary care doc they might have had for 25, 30, 50 years in some cases. Now tell me a little bit about a more elderly patient that comes into hospice care. What's a scenario? They get diagnosed with a disease at a hospital or at home? What's the circumstance?
Here's the worst case scenario.
Yes.
The worst case scenario is that someone with advanced cancer has continued to get treatments beyond any form of support.
Okay.
And then the treatments have their own toxicity, and they've ended up in the hospital with infections, with the complications of bone marrow suppression or other kinds of things that they never bargained for in the first place.
Right.
And that hospice referral is made, and it's true. We can shepherd people from the intensive care unit into their home,
Right.
and we can do it with a relative sophistication, with breathing machines or other types of things that they need for that transition.
Yes.
But their life with us is days to a week. And I think that's where people think, hospice, that's the death sentence. If they say the hospice word, then that's the end of life. Here's the best case scenario. I met with a couple yesterday.
Yes.
She came in and said, I have advanced cancer. I'm very, very informed. I'm very active. I'm really doing everything I want to in my life, but I want to talk to you about the hospice benefit. I want you to know me. I don't want to come onto hospice now, but I do want to at some point, and so I'm checking you out. That's the best case scenario, because when she showed me her scans, I looked and it said, she's right. She has advanced disease, and she's really performing at a high level. She does qualify for the hospice benefit at the point where one or two of her activities of daily living, like being able to dress herself, bathe herself, toilet herself, and so forth, when someone needs to provide support for two of those fundamental activities of daily living, they're hospice qualified with an advanced cancer.
Okay.
Similar for heart failure. The patient that comes in and out of the hospital for heart failure. We would really like for that patient to know about palliative medicine in the hospital and engage with hospice care when they have that high stage heart disease where they can't take that flight of stairs easily without being short of breath, where they're being rehospitalized, they come in, they get tuned up, they go home again. Our role in hospice is to be sure that that tune-up continues in their home rather than shuttling back and forth. Same thing for those people with chronic lung disease. They get into trouble with that shortness of breath, the medications that they need. What we often find, Josh, is that people are prescribed medications even after years of having a chronic illness. They don't know how to take them correctly. And we can eliminate some of the toxic medications that they may be taking because they always took those before, and that sometimes their doctors don't even know they're taking. So with those diseases, with kidney disease that you pointed out, with neurologic diseases, with dementia, stages of dementia, hospice is a benefit that's available.
This is such an important discussion, and I'm so pleased we're having it today. I think what we'll do is we'll take our next break, and then when we come back, we'll further explore the capacity that people have and the access they have to hospice care. We'll talk about some of the barriers, perhaps, that people have historically had to getting this service. So let's take our little break now, and then we'll come back in about a minute. Again, I'm Josh Green with Healthcare in Hawaii. your host today, speaking about hospice care in our state.
We want to thank our underwriters.
Hawaiian Electric Company and its affiliates Maui Electric on Maui and Hawaii Electric Light Company on Hawaii Island are deeply committed to the communities they serve.
Galen Ho is a senior executive of BAE Systems, a global defense, security, and aerospace company.
The High-Tech Development Corporation, the state's leading technology agency, attached to the Department of Business, Economic Development, and Tourism.
Castle and Cook Hawaii, with a time-honored legacy that spans more than 160 years and revolves around its mission of investing in Hawaii, creating communities, and providing for the needs of our state.
Hawaii Gas, formerly the Gas Company, a proponent of the Liquefied Natural Gas Initiative, helping Hawaii achieve its transition to clean energy and a better energy future.
Collateral Analytics, a Hawaii-based tech company empowering the real estate industry with greater and faster access to the tools and data they need to make better informed property investment decisions.
I'm Nicole Horry. Thanks so much for joining us on ThinkTech.
I'm Maria Kashem. See you next time.
Aloha, welcome back to Healthcare in Hawaii. I'm Josh Green, your host, State Senator from the Big Island and ER physician. Today I have Dr. Geoff Galbraith, who's an expert on palliative care and hospice care here in our state. Hospice care is a service that's available to all. We've been speaking about this quite passionately for the last 30 minutes, but I wanted to throw out a couple numbers at you so you know how broad an available service this is in our state. As of 2011, 1.65 million people in the United States received hospice services in one form or another. 44.6% of those who were under care received it in that particular case and received for just under 7 days. My apologies, 35.8% received for under 7 days. 27% received for the services for up to a month. But in some cases, what Dr. Galbraith is telling us is maybe hospice care would be better if people got more acquainted with it early so we could decrease the pain and suffering and their concerns about how to deal with the complexities and some of the things that we don't love about our healthcare system earlier. The services that he's described to us are very personal. They're spiritual, they're emotional. They make it more available to get health care to decrease a person's suffering when they have a chronic disease that might mean the end of their life sometime in the next 6 months. So I wanted to speak about some of those statistics because it's really quite a prevalent issue that people can get to hospice care, but many people don't know about it. Why do we think that that is? What's been the barrier for everyone to understand I have the right to get a hospice care consultation when I'm suffering from a disease that could mean the end of my life? What's been the barrier, Geoff?
Several barriers. First, I don't think any of us in America want to talk about death.
Okay.
I think we all accept birth as a miracle.
Yeah.
We're just not really looking at the process of dying as potentially miraculous most of the time.
You're right.
I don't carry a business card typically because my card is not in demand. And I think the idea about that is that sometimes if you talk about something, maybe it will happen a little bit sooner. So people do equate hospice with dying, and sometimes hospice with, well, you go somewhere and they give you these medications to reduce pain, but they also accelerate your dying process. And that's just not true. So we have a lot of misconceptions. Hospice is the beginning of the next part of your life with chronic illness, not the end. I want to just make it clear to our viewers that there are people that graduate from hospice.
Really?
I've had a patient that had documented lung cancer with metastases, and over the process of the 18 months that we cared for him, very legitimately, he became less symptomatic, and at some point I just said, stop. I have to call your physician. I called and said, he's doing well enough that if you don't mind, we'd like him to leave the hospice service and come back to you for imaging to see how he's doing. And he went back for imaging, and his cancer was not detectable on a CT scan. Now, I don't mean to talk about miracles. That seems miraculous to me, but there are people that get the service and they get better. They're taking medications more effectively, often fewer medications than they were taking.
Right.
They're encouraged to do different things that rehabilitate themselves, like physical or occupational therapy. And they're encouraged to have that positive attitude that this is the beginning of something new. I've got an adventure here to do. So the team focuses on that. In our country, that close association, now we're at 30 years into hospice care.
Okay.
Dame Cecily Saunders from the United Kingdom was a social worker, a registered nurse, and a physician, all of which was every time she saw a need, someone said to her, you have to go and get a different credential or you can't do this. She became a physician. She invented hospice at the St. Christopher's Hospital, and that spread to the United States in the early 80s. So it's been here for 30 years. It's been a benefit since 1986, mandated by Congress, but it hasn't, we've done a terrible job of communicating with people about how remarkable this benefit is. And now that we're more and more sophisticated about using the smallest amount of medications and specifically targeted to end nausea, to end this sense of fatigue so that you can feel more energetic, to really remove pain so that you can perform more effectively in this part of your life, people need to know this, and your show and others like it that are informing the public is a gift to us.
You touch on so many important things, I almost don't know where to start. One, as I think of what you say, I think one of the probable reasons that people do so well in hospice care is that they get such comprehensive attention to their healthcare needs. Whereas in the traditional fee-for-service healthcare world, where a doctor sees you for 10 or maybe 15 minutes, maybe a little longer in the ER, you don't get a comprehensive view of the patient in many cases. Whereas in your case, it sounds to me like people are spending a lot of time with a patient that enters into the hospice care system. How much face time does a patient get when they enter into the program?
I think they get as much as they need and is appropriate for their current state. So often, if someone comes into hospice, they've been very ill and they need more attention. So they may get several nursing visits a week. In a week, they may get several social worker visits. They may have a home health aide in as often as every day to make sure that the home is set up, that the loved ones understand what they can do to care, and they're not afraid of caring. So that can be pretty intense in that first week or two.
Right.
Then if you get things stabilized, then the family wants to say, like, listen, it's not normal to have everybody here all the time. Let's chill a little bit. So the nurse comes once a week. The social worker checks in as often as the family thinks is necessary. The chaplain is available so that we can start talking about that spiritual life that is so important. That may be less intense, and then we may get more intense toward the end of life when symptoms get worse, pain gets worse, breathing gets more difficult. So then we're in more, I'm personally in people's homes more of my day. I don't have an office that people come to see me. I get to be in their home, the privilege of being invited into their lives to deliver care. One other thing about hospice care that I want everyone to know, we're interested in the next 60 minutes. It's not take 2 aspirin and see me in the morning.
Right.
And it's not we'll see you in a week. I want to know in 60 minutes if this pain is improved. If it's not, we're going to do something different for the next 60 minutes. And if it doesn't work at that point, then you're going to be visited by the nurse or by me.
Got it.
So the medical directors in our state are very active about being in patients' homes when they're on hospice care, along with the rest of the team.
Well, you know, I think that most viewers would admit that that's a very different and wonderful service that one could get, because I think a lot of times in our current modern healthcare system, people have found it somewhat aloof. We provide wonderful healthcare with our technology and our physicians across our country, there's no question. On the other hand, a lot of times maybe it's been impersonal, or it's been about testing. It hasn't been about that direct touch, which is what it appears hospice care can offer to patients who are in need. So I think that really speaks volumes about what the program is, and it's becoming. I mean, I can see that the healthcare system is now embracing hospice care much more. I'm hopeful that with the changes with the Affordable Care Act, and there has been an increased focus on people not going into the hospital as much and to be cognizant of end-of-life care and costs, that we will utilize a service that seems to be functioning so well as a part of the healthcare system, which is hospice. Are you seeing that? Are you seeing an increased focus on hospice services and palliative services since this large dialogue about healthcare reform has kind of erupted in the last few years?
We are seeing, and as with almost everything in medicine, we're seeing the good, the bad, and the ugly.
Tell me.
The ugly is that hospice is a benefit where hospices are paid on a daily rate for routine care, and they're paid at a higher rate for intensive care, usually in a facility. And anytime that there is the flow of money, someone is worried about who's gaming the system. So right now there's a lot of scrutiny about hospices for good reason, because there's a lot of money that's being invested in hospice care. Are you being careful about eligibility? Tell me about your plan of care. Can we see in your electronic medical record that your plan of care is really changing and is improving for the patient? Can we see that they continue to be eligible, or should they be discharged from hospice because they've gotten better and welcomed back? Something important for your viewers: you don't lose your hospice eligibility. You can't blow it. You can revoke it, where you say, you know, I want to try this new therapy. There's a new heart device. I want that defibrillator. So I'm going to leave hospice care. I'm going to revoke your service. I'm going to work with my cardiologist, my cardiac surgeon. I'm going to have this brand new defibrillator. I'm going to be a new person. And we say, bless you, have it your way. We wish you the best, but we're here for you. If you need our service again, we're right here for you, and you don't lose your benefit. So it's important that people know that the benefit is a lifetime benefit. It's not limited that way. That also is part of the good news. So the bad news is more scrutiny, probably less payment. It's fine. We all need to contribute our share. Right. The good news is all of the studies are helping us understand that when you have the good conversation about your wishes early,
yes.
And for example, our state was one of the early adopters of the POLST, the Physician's Orders for Life-Sustaining Treatment. You, Josh, and your colleagues in the Senate and the House made it real that people could do something, have those good conversations, have a person that they say, you're my healthcare decision maker with me, without having to go to a notary public to have it done in triplicate for a system that may never see it. But we've got those big green forms that says, this is what I want if I get into trouble.
Right.
And I can't make my own decisions. So we're being now supported in having those conversations more effectively with families.
Right.
As you know, there was a period a few years ago where we weren't being supported with that conversation.
Yeah, I take that I take that personally to heart. You know, I think you and I spoke off camera a little bit about when people put these labels on things like death panels and that discussion. You know, I think we're smart enough in America to know that we're not trying to do anyone any harm, and when people are being rational, that's not the discussion that's being had by the healthcare community. But what was your reaction when people framed the question, instead of about advanced directives and POLST, about what you might want when you, if God forbid, you had a severe event that left you incapable of making your own health decisions? What was your feeling when that discussion happened and people used words like death panels?
I was entirely shocked. The hospice and palliative care community was entirely shocked, because the conversation literally was about giving an incentive to physicians to have those important conversations with their patients and their patients' family members. Right now, there's no financial incentive to sit down in an hour-long conversation to really discover what someone would like for their future if they're not able to talk about it, or they're not able to direct the care. Do they want a full intervention that includes cardiopulmonary resuscitation, ventilators in the ICU, or do they want comfort measures? Do they want feeding? Do they want intravenous support? Do they want things that are not interventional but really can help them, or do they want pure comfort? So that was what the conversation was, and then someone changed that into, that's just America having death panels that will eliminate eliminate people's options and save money by having them die sooner.
Yeah,
I was disappointed.
Yeah. Well, I think the good news is we've been able to rise above that level of conversation and have more conversations like we're having today. So I think why don't we take a brief break and then we'll come back for our final segments and we'll talk about your vision for healthcare in the state of Hawaii and how hospice care fits into that. Sound all right?
Yes, thank you.
You bet. Again, I'm Josh Green with Healthcare in Hawaii. We're so pleased you joined us today.
Aloha, I'm Jay Fidel. This is ThinkTech Hawaii, broadcasting live from the Pioneer Plaza in downtown Honolulu. We raise public awareness about tech, energy, and globalism in Hawaii. Technology is critical to our state. A vibrant tech sector will give us new prospects in the global marketplace and will offer great careers and make our economy more resilient. Streaming live on Ustream and Spreaker, ThinkTech allows its hosts and guests invaluable opportunities to report important events and discuss important questions, and to be heard here in Hawaii and around the world. You can find links to our live streams on thinktechhawaii.com or on our mobile website, m.thinktechhawaii.com. And you can see our archive on YouTube. It's all just a click away. We want to do whatever we can to keep Hawaii relevant, connected, and thriving in the complexity of the 21st century. We hope you will help us in those efforts. Tune in today. This is ThinkTech. I'm Jay Fidel. Mahalo.
Aloha, welcome back to Healthcare in Hawaii. I'm Josh Green, your host. I'm an emergency room physician and also a state senator representing the Big Island of Hawaii. Very passionate about healthcare, and I've been extremely fortunate today to have an expert on palliative care and hospice care in Dr. Geoff Galbraith, who's the medical director of Hospice Hawaii here on Oahu. I want to ask Dr. Geoff what his vision for healthcare is going forward in Hawaii and how hospice care can impact that.
First, my vision would be that we're able to have these kinds of conversations more frequently in public settings, in long-term care facilities, in clubs, in areas where people in their own comfort get to talk about things that can feel taboo. That would be a dream. Second thing is I would like for the physicians that are often in the place to refer patients for hospice realize that they can bring hospice in sooner in their treatment plan so that there is a conversation that's well informed and a person is able to talk about hospice care. They may not go on to hospice, but they have all of the sense of what the benefit might be for them. Sometimes physicians particularly have worked closely and hard with someone, they don't want to give up, and even they feel like, oh, hospice, that's giving up on my patient with cancer, or my patient with heart failure, or my patient with lung disease. Not so. We want to build that collaboration, closer teamwork. So I'm looking forward to that, and we're now being supported in having more of those conversations with specialists. So I think that that's going to be something more matter of fact with time here in Hawaii across all the islands.
I really agree with you because I think that we've seen an evolution of so many of the larger challenges in healthcare change dramatically. I remember in the early days when people were alcoholic, there was a period of time where it was very difficult to talk about alcoholism in the primary care setting. Now it is completely matter of fact and easy to speak about. Same thing then happened with drug addiction. There were issues that people didn't want to come clean about those issues in their lives. Or HIV/AIDS, really serious challenges in people's lives that we knew as physicians were healthcare concerns, and we weren't meant to judge them, but they became part of the overall health discussion, and people got better. And I don't mean to necessarily equate hospice care, end-of-life care, in any way, shape, or form with each of those individual issues, health issues, but I do recognize a pattern where as we become more comfortable with different parts of the healthcare system, we do better, and I think that's what you're saying. I would comment, this has been a very important discussion for me today because 36 hours ago, I didn't even share it with our producers, I just spoke a little bit about it with you. 36 hours ago, my uncle had a catastrophic stroke, and he is right now in the intensive care unit, and he may very well die. And he's an educated man, a prominent lawyer back on the mainland, has had health challenges in his life, but most of us would look at him as a pretty healthy guy, probably even appears healthier than I am even at a young age. But he had this very tragic event, this stroke, and his family will benefit if they need hospice care or supportive care from the team should he not improve. And we're all praying for him, of course, and he's got a fantastic team of physicians. But this is something that it's really such a blessing that it could be a part of his life if they need the services. Whereas in the past, I think people might have been very reticent about discussing. I would hope that all primary care physicians, all specialists become familiar with what you offer. Is that the message that you're trying to send?
That really is the message. And if you take certain examples, at Queens Medical Center, they are seeing that there's a potential link with hospice care directly from the surgical intensive care unit, directly from the medical intensive care unit, because the skill sets that are now available in people's homes can allow a safe transfer to that place where I'm most comfortable. If I have the remaining days where your uncle is very, very ill, but if he could be in a place where he has a view of his lawn or the vista over Kaneohe Bay, how much might that mean to him, to his family, to your larger ohana? So that very much is our goal, to be more accessible and more present.
Well, I'm so pleased that we've been able to have this hour here today together. I hope that our viewers, especially our medical community viewers, take to heart these possibilities, that this is a benefit that all people have access to. I was very impressed by one of the things you said earlier, that many people live longer and have a healthier existence when they're in hospice care, that some people graduate from hospice care if they get better, and that it's really becoming a central part of our healthcare system that we should all embrace if we have the opportunity. So thank you for joining me today.
It's been my privilege.
I hope we have these discussions further in the future.
Thank you.
Thank you all for joining us here in Healthcare in Hawaii. It's been my pleasure, Josh Green, your moderator, to talk about hospice care in the state of Hawaii with Dr. Galbraith. Thanks again for joining us.